Hello, everyone, and welcome to today's Enduring Material webinar on clinical considerations of substance abuse and critical components of proper prescribing. Today, we will be discussing the COVID-19 MAT regulations and buprenorphine regulation amendments. With us is our featured speaker, Dr. Mark Jorich. But before we get started, let me share a few pieces of information related to CME. First, this enduring material is accredited for one AMA PRA Category 1 credit. Physicians should only claim the credit commensurate with the extent of their participation in the activity. In addition, CME certificates will be generated via email to attendees upon receipt of a post-activity evaluation through SurveyMonkey. These CME certificates are being generated on a weekly basis through the end of December 2020. If you have not received your CME certificate within 2 weeks of the view date of your CME participation, please contact the KMA offices, either at my email address, mosley@kyma.org, or Heather Lathan at lathan@kyma.org. With that, we'll turn this over to Dr. Jorich for his presentation.
Good afternoon, everyone. Appreciate being invited to talk to you. I have been charged with speaking to you about regulations for surrounding medications used for treatment of opioid use disorder. Regulations can sometimes be a bit tedious, so I wanted to perhaps make it a bit more interesting by sort of taking you on a tour, basically to talk about how this all developed, what our standard regulations have been, and then what kinds of flexibility have been generated because of coronavirus pandemic. Surely I will not be able to go through what all the regulations are. I'm happy to discuss with any of you should you want to contact me and speak about any of the specifics. Having a slide problem, let's see. Sorry, trying to get through the slides. There we go. Okay, so opium actually, commentary about it goes back many, many years. Actually, if we go back to the 3000s BC, ancient Egypt, we hear about opium being used for a variety of reasons. It was medicinal, it was ritual, and as well it was euphoria producing in seeking reward. Jumping ahead, we then see opium coming to the United States in the 1600s. This was mostly immigration from Asia, smoking of opium, and it became more and more commonplace, again used for a variety of reasons, oftentimes for euphoria seeking. 1806 sees the development of morphine. And then with the development of the syringe in 1853, we start seeing more and more use of opioids, and particularly during Civil War days for treatment of pain and other medical reasons, it became, as I say, more commonplace. Heroin was developed in 1874, and that resulted in the Bayer Company, 1898, producing heroin on a commercial basis and advertising it as a non-addictive morphine substitute and cough suppressant. Hearing that kind of attachment to heroin, one can only guess that this was going to be a growing problem, and it did lead to increasing use and problems with heroin addiction. As a result of the increase in problems, the government felt that they needed to step in and create some limitations, and therefore we have the beginning of regulations. This starts in 1909 with what was called the Opium Exclusion Act. It barred importation of opium for smoking. The next act was in 1914, the Harrison Narcotic Act, which actually, again, increasing problems. It put a tax on opiates as well as cocaine, but also was going to address the administration and prescribing of opioids, narcotics in general, by physicians and as well pharmacists, and placed some very severe consequences. And as a result, physicians were actually being arrested as a result of that. There were fines, there was imprisonment. In 1924, the Heroin Act was an amendment to the 1909 Opium Exclusion Act. It prohibited importation of opium for the manufacture of heroin. A growing problem, more and more addiction. These initial regulations really didn't have the impact, and attention was then turned to the possibility of treatment for opioid use disorders. What we see then in 1929 was what was called the Porter Narcotic Farms Act. This brings us very close to home. It was a U.S. Public Health Service project and opened two narcotic farms, as they were called, one in Lexington, Kentucky, and the other one west of the Mississippi, Fort Worth, Texas. And this was to promote increasing treatment, not just for opioids, but for a variety of substances. Treatment was voluntary, but it was not really a successful program because it utilized a variety of techniques, and you can see what I have listed there as far as electroconvulsive therapy, hallucinogens, lobotomies, adrenocorticoid extracts, many of which did not work. And as a result, these farms were closed down. The one in Lexington became a federal prison in 1974, but continued to maintain as a psychiatric hospital until 1998. But the reason for all this was the fact that there was development of newer, different kinds of medications, different approaches to treatment, which brings us really then to the more recent era of treatment. And as heroin addiction grew, deaths grew, there was work then done at Rockefeller Institute in New York by Dole and Niswander. This is in the mid-1960s. They were working with methadone, which had been around since the 1950s and probably earlier than that. But they were working with methadone and found that methadone in appropriate dosing could suppress withdrawal and craving for heroin addicts. 1970 sees the Controlled Substance Act during the Nixon era. Again, this was a move to try and emphasize the need for treatment, research, taking less of a punitive and criminal justice role. This act provided for the scheduling of controlled substances. It established the National Commission on Marijuana and Drug Abuse, suggested decriminalization of marijuana, and eliminated mandatory minimum sentencing. The result of all that was then in 1972 with the Drug Abuse Office and Treatment Act, which established NIDA, but also established the regulations surrounding OTPs, opioid treatment programs, and methadone was approved for treatment. Again, I want to emphasize all of this legislation did focus on prevention, education, as well as treatment. The federal block grant program in 1982 then created subsidies for being able to manage OTPs and with real attention to special populations, pregnancy, intravenous drug use, patients with tuberculosis, HIV, and AIDS. Unfortunately, things turned a little bit in 1987 with Reagan war on drugs. There really was a shift back from treatment, punishment with harsh sentencing, mandatory minimum sentencing. Nancy Reagan's program of Just Say No was introduced, which really didn't work all that well. On the more positive side, the Office for National Drug Control Policy was established as a result Reagan's war on drugs. Now we get to the even more recent history. Increasing problems. None of this was really working well. OTPs, yes, there's lots and lots of research, even back from the 1960s, supporting, but really the utilization of OTPs in methadone treatment was quite limited as far as accessibility and availability of treatment. Prior to 2000, the medication buprenorphine, which we know in a trade name as Suboxone, was being used pretty regularly in Europe and was found to be very helpful in treatment of patients with opioid use disorder. And as well was felt to be a bit safer than perhaps methadone. Probably didn't carry the same kind of stigma that methadone had then and perhaps continues to have now. So with Data 2000, Drug Abuse Treatment Act of 2000, and another option was made available for treatment of patients with opioid use disorder. This permitted the use of Schedule 2, 3, and 4, Schedule 3, 4, and 5 medications, FDA approved for treatment of opioid use disorder in an office-based setting. There were some restrictions. It necessitated that physicians were to be qualified. There were medication requirements. There were patient limits. Qualified physicians needed to meet one of the following categories. They either did have credentials and certification in addiction medicine, psychiatry or addiction medicine. They were an investigator in buprenorphine trials. They completed an 8-hour training course, or they were grandfathered in for a variety of reasons by a state medical board. The physician needed to have the capacity to refer patients for counseling and ancillary services. Medication alone was not going to be enough. And they needed to obtain from the DEA what is called the X number, or a waiver DEA license, in order to prescribe buprenorphine. The medication requirements identified the fact that this was a Schedule 3, 4, or 5 medication, controlled substance, that it had been approved by the FDA, and lo and behold, the only medication available meeting these qualifications was buprenorphine. But not all formulations of buprenorphine met the criteria, because certain formulations were not approved for the treatment of opioid use disorder. The limitations on patients, in terms of how many patients could be treated, originally were 30 patients within the first year. That would increase to 100 patients in the second year for, again, qualified physicians. We, however, saw an update to this rule in August of 2016, which said that after 1 year of treating 100 patients, qualified physicians, that is those who had a specialty certification or those who were working in a qualified practice setting, could actually increase their caseloads to up to 275 patients. The definition of a qualified practice setting is the practice needed to have coverage for medical emergencies during off hours. There needed to be access to case management services. Again, not just medication, but the necessity for counseling and social supports, using health information technology, that the practitioner was registered in the state prescription drug monitoring program, our CASPR system, and that would accept third-party payment for at least some services. The next step in use of buprenorphine was the CARA Act, this in 2016, and it continued to support prevention, education, overdose prevention with naloxone, medication-assisted treatment, but then extended prescribing privileges to nurse practitioners and physician assistants. However, the requirements for nurse practitioners and physician assistants were a bit different. First of all, the CARA Act will expire in October of 2021, and I would be very surprised if it was not renewed. Educational requirements were different in that there were 24 hours of education required, and if a state required a collaborative agreement, supervised agreement, that needed to be done by a qualified physician. Not all states required that. Nurse practitioners and physician's assistants could take care of 30 patients in the first year and then apply for up to 100 patients in subsequent years. The last step in this process is what was called the Support Act, Substance Use Disorder Prevention, that promotes opioid recovery and treatment. And again, trying to increase flexibility. The crisis was ongoing, increasing mortality, increasing morbidity. Patients needed more access to treatment. And what this did was extend prescribing privileges even further to a number of nurse specialties, certified nurse anesthetists, nurse specialists, nurse midwives. Also then changed the ability for physicians to be able to treat up to 100 patients in the first year of their waiver, this rather than 30 patients. Again, qualified that they either were a specialist with board certification or working in a qualified practice setting. Again, this is the definition. I won't repeat what a qualified practice setting is. But it also said after that first year that physicians, practitioners could increase their census, their caseload, up to 275 patients. Let me now turn from that set of regulations and programming for the use of buprenorphine and look at just what happened during this period in prescribing controlled substances in general and controlled substances for pain. I've alluded to the increasing problems. I think we're all aware of what we faced in late 80s, early 90s. Pain, chronic pain became an issue. Pain is the fifth vital sign. The push to manage pain in a much more aggressive way. What seemed to be the understanding that if patients were at low risk for addictive disorders, using chronic opioids would not create any problems. Unfortunately, this did not hold up. It created a whole host of problems, and again, we saw the problems of increasing addiction and increasing mortality and morbidity. The KBML and legislature were then asked to address this. And what they did in 2012 was pass what we know as House Bill 1. And this was for the regulation of pain clinics and to address prescription drug use. Paid a lot of attention to use of CASPR reporting, our prescription drug monitoring program, that CASPRs needed to be obtained prior to writing a Schedule or 2 or 3 prescription, that there needed to be review of CASPR reports with longer term prescribing of opioids, that if one was dispensing from the office opioids, it was limited to a 48-hour supply, and that there were mandated educational requirements in addiction and pain management for all prescribers. It also spoke to a coordination between licensing boards and Kentucky State Police, the Office of the Attorney General, the Office of the Inspector General. It required overdose reporting with coordination between medical examiner, state police, Office of Drug Control Policy, Office of Vital Statistics, and coroners. Then it also said that practitioners coming into the state seeking licensure, if they had had restrictions, the board was to honor those restrictions that had been placed on a practitioner prescriber from other states. And if the prescribers didn't report, the consequences were quite serious, leading to conviction, loss of prescribing privileges, and actually could result in incarceration. As a result of House Bill of 2012, the Kentucky Board of Licensure then developed a set of regulations, and I have these here for reference, guiding the standards for prescribing opioids for the use in chronic pain, as well as for the use in treatment of opioid use disorder. Next year, in 2013, House Bill 217 modified House Bill 1. It required a complete history and physical, and I can't emphasize the importance for this. We need to be good physicians and practitioners and good evaluators of medical problems. It emphasized CASPR reporting requirements, and it did also create some exemptions in terms of this prescribing, because we saw special situations that could arise in hospitals, long-term care, emergency, post-op, and hospice. Lastly, it modified the standards for who could be an owner, who could be a medical director of pain clinics. In 2017, House Bill 333 did a few things. One, it was looking at fentanyl, and as we started seeing fentanyl use increase, and also then some of the derivatives of fentanyl, it identified those derivatives as Schedule I controlled substances. But it also mentioned and stated that in using Schedule II controlled substances for acute pain, this was to be limited to a 3-day supply. Of course, there were still certain exceptions, but the base was to be a 3-day supply for acute pain. I will now turn to opioid treatment programs, what we might call methadone clinics. These clinics, I've gone through some of the regulations that established these from 1972, are in the, what we call the CFR 42 Code of Federal Regulations. They are programs that originally were overseen by the FDA, and this has been handed off to SAMHSA. But I want to emphasize that these are highly regulated programs. They don't only answer to SAMHSA, but they also answer to Health and Human Services, the DEA, the OIG, and state by state. That is actually in this next slide here that identifies that. And each state has the authority to modify what the federal regulations are. The federal guidelines are published because all programs need to be accredited, and these are used by accrediting organizations, JACO, CARF, to help clinics meet the qualifications and standards of good treatment. OTPs, again, answer to SAMHSA, the DEA. They are programs that administer, not prescribe, methadone on a daily basis, although they are permitted to use buprenorphine on an administered basis if need be. Patients come to the clinics on a daily basis. There are also other qualifications. Patients get routine drug screens, routine CASPR reporting, routine counseling. There are collaborative agreements with a variety of community programs for social supports. So it takes a lot to, one, for the program to meet the regulations, but also for the patients to meet the requirements of what an OTP is. These, I alluded to the 2015 update guidelines. Important in Kentucky is the fact that as of January 1st this year, 2020, DCBS reviewed and updated the guidelines and the regulations for OTPs. Was really a positive step. They too recognized that it's a difficult program to follow, and made it a little bit easier for program physicians to get qualified to see patients. It looked at the ability for patients to earn take-home doses rather than coming in on a daily basis. These can be earned a lot more quickly, really, and a variety of other changes that resulted from these new regulations that had been long in coming. Another big change for OTPs was again, January 1st, 2020, from the Centers for Medicare and Medicaid Services. They approved payment routines for OTPs. Now, many states had already approved and were paying for methadone treatment. This was not happening in Kentucky. Again, that's the highlight. This is an administered medication, not a prescribed medication. But as of January 1st, this has changed, and I, from a personal experience, have seen great growth and ability for patients to enter and continue treatment because finances are not such a large barrier. In Kentucky, let's talk about some of the changes that have happened in OBOT, office-based opioid treatment. That is treatment of opioid use disorder with buprenorphine. Data 2000 established the original guidelines. And Kentucky practitioners were treating in Kentucky. The KBML set up some standards in 2015 for the prescribing of buprenorphine. And this slide is a touch old, maybe just a month old, that not pending update, but this month the KBML did approve a new set of standards and an update which will be instituted this next month, October. Let me review some of the highlights, because there have been lots of questions and there continue to be lots of questions, and it is just a process that will require future updates. Because of new formulations of buprenorphine, specifically implants and depot, the language had to be changed so that FDA-approved uses of buprenorphine identify the formulations that can be used. There continues to be emphasis and limitations on use of buprenorphine for pain, and again, that alludes to what is FDA approved for addiction treatment and what is FDA approved for pain management. Buprenorphine mono, that is buprenorphine without naloxone, has classically been used in pregnancy and was also permitted for objectively documented allergy. The mono product, however, can also now be used for induction, for transition from methadone to buprenorphine, and for in-hospital administration. Where the physical exam needed to occur prior to that first prescription, it is now permitted to get a patient into treatment, and as long as the physical exam is completed within 2 weeks of that admission. There has also always been the limitations and major concerns about the use of benzodiazepines, and this is maintained, that they are only to be used in coordination, in consultation with experts in the field. Treatment during pregnancy, there's continued mandate for consultation with OB. We have always recommended in-office induction, but now under well-documented circumstances will approve at-home induction. Really want that to be limited and with proper instructions. Random drug screens are no longer mandated. This does not diminish the fact that we expect physicians, practitioners to monitor patients for illicit drug use, to monitor patients for diversion, still ongoing problems. In emergency situations, waivered physicians can initiate treatment with buprenorphine without having to first complete the entire intake process. That can be completed at a later stage. This hopefully also will get patients into treatment sooner. The American Board of Preventive Medicine is recognized because this is the specialty organization for addiction fellowships and addiction specialty. The guidelines begin to then address physician assistants who are under the oversight of the Kentucky Board of Medical Licensure. PAs have been held to this regulation, but this will be formally adopted as the new standards are adopted. And no longer is there a mandate to report lost or stolen medication to the police. Yes, it needs to be addressed and addressed individually, but not to be necessarily be reported to the police. We will talk now about what's happening in this time of coronavirus pandemic. SAMHSA, DEA, KBML, and the AMA have all issued guidances and created some changes to really address safety. I'll go through each of these individually here. In talking about OTP dispensing, as I've mentioned, OTPs require patients, at least at the outset of treatment, to come in on a daily basis. It takes a significant amount of time to earn take-homes, and therefore there's a lot of face-to-face interaction in clinics. What SAMHSA has said is that states may request blanket waivers, blanket exceptions, and permit longer periods of take-homes. If the state is not in an emergency situation, clinics on an individual basis can do that. And so this is also, their directive has also addressed office-based opioid treatment and permits greater flexibility in prescribing from what may be weekly appointments to be able to have patients come in less frequently. What this has led to, as far as the blanket exemption, is that patients who have been stable, who are deemed stable in treatment, could get up to 28 days of take-homes. Typically, this could take some years to get to the point of coming in, if you will, once a month. And patients who were stable, but perhaps a bit less stable, could get up to 14 days of take-homes. Because of this public health emergency, the sticking point of an initial evaluation, which needed to be done face-to-face, and this, now I'm talking about prescribing of controlled substances in general. That has been the general rule, that before prescribing any controlled substance, there did need to be this initial face-to-face evaluation. However, with the public health emergency, changes have come, at least temporarily, that practitioners may issue prescriptions for controlled substances to patients for whom they have not conducted an in-person medical evaluation. Now, mind you that this needs to be for a legitimate medical purpose. There needs to be a clear two-way interactive communication system, that is telehealth, and it needs to meet applicable federal and state law. It has always been possible that after an in-person medical evaluation, the practitioner may issue a prescription for a controlled substance after having communicated with the patient via telemedicine, as long as it meets applicable state laws. So nothing changes with that, although most of us would prefer a face-to-face evaluation for any prescription. with coronavirus and limitations in the ability for face-to-face, the electronic prescribing or the prescribing without face-to-face is permissible. And when I say that they have your back, that initial slide at the bottom said they have your back from the DEA perspective. If a physician is unable to conform to professional standards, and this is not just for this coronavirus period, it has always been, as long as physicians, practitioners, prescribers are using good sense, common sense, good judgment, document, justify the need for moving outside the lines, this will be acceptable prescribing. We have always known that a pharmacist may not dispense a Schedule II controlled substance without a written prescription. However, there always has been the ability to do this, that is an oral prescription, if the pharmacist has authorization from the practitioner. It must meet these qualifications. The quantity prescribed and dispensed is limited to the amount adequate to treat. The prescription is immediately reduced to writing by the pharmacist. That the pharmacist makes a reasonable effort to determine that this is coming from the practitioner, and that a paper prescription is followed within 7 days after an authorization of that emergency prescription. Lastly, it's to have on that prescription authorization for emergency dispensing and the date of the oral order. There have always been questions about the ability to dispense as well as prescribe controlled substances across state lines. The DEA has always required registration in both states. However, with coronavirus, because of fewer face-to-face interactions, the DEA is saying that prescribers may dispense out of state, they may prescribe out of state without DEA registration in both states. Now, I need to also tell you, and for much of this information that I give you, please remember I am not a lawyer. The state of Kentucky does require that if you're going to be prescribing over state boundaries that you register with the state of Kentucky. And the KMA and the KBML have support for you if there are any questions about some of the things that I am relating to you. The DEA in telemedicine, there is an emphasis to use telemedicine for safety, particularly in OTPs and in with OBOT treatment. Confidentiality. Confidentiality has always been a very serious issue, particularly in the field of substance use disorders. But with telehealth, it creates some problems. And SAMHSA has said that they will waive potential health insurance HIPAA penalties for good faith use of telehealth. Now, the same confidentiality rules apply if it is a face-to-face treatment. It's only for telehealth that they will look at alternatives. The CARES Act is something I think we're all familiar with. This was legislation that was passed in March 2020, signed by Congress, signed by Donald Trump, with the coronavirus pandemic. And there was a fair amount of impact in the healthcare field. Just to read, it allocated $130 billion to medical and hospital industries. It provided $145 million in grants for telehealth, allows the disclosure of de-identified patient medical records, and I'll get to this in terms of confidentiality, and it increases Medicare payments to medical providers during these dates. CARES Act was enacted to provide emergency assistance to individuals, families, and businesses, and specifically intended to address confidentiality issues that have existed for some time in the addictions field. 42 CFR being the regulations guiding substance use disorder treatment, 42 CFR Part 2 guiding the confidentiality requirements were pretty severe and really limited the ability of communication from practitioner to practitioner, from clinic to clinic, in being able to provide the best care possible for patients. So in order to provide flexibility for patients and healthcare providers, there was a change to the CFR 42 CFR Part 2 confidentiality standards so that it would more closely align with HIPAA. These 42 CFR Part 2 were a final rule in 75, amended in 1987, but in 2016 there was presented a proposed rule. Again, updated regulations to allow for better information sharing. The final rule was amended in July 15th, effective August 14th. Now, the CARES Act itself won't become formalized until 2021. So this final rule for 42 CFR is basically a temporary patch to get to the point where the CARES Act will go into effect. I'll brief through that slide. And so let me just address some of the things that you will see with this final rule for 42 CFR Part 2. Consider when a Part 2 provider, Part 2 meaning somebody dealing with substance use disorders, orally presents information to a non-Part 2 provider. That confidentiality is much more flexible, and that non-Part 2 provider can make that information a part of their usual chart. Consider when a Part 2 provider provides records to a non-Part 2 provider in a written form. That too can be made part of the non-Part 2 medical records, as long as it is segregated in a different part of the chart. Now, I need to emphasize, and I'll emphasize this later, it still does require consent, written consent of the patient. When that non-Part 2 provider is working with the patient, is gathering information on the possibility of substance use disorder, substance use, that too can be made a part of the usual medical record and can be disseminated in terms of redisclosure to other entities. Whereas releases of information have always had to be very, very specific. It needed to identify from whom and to whom information would be moved. It now provides for a much more generalized process, that the release of information can be just a general release of information, therefore letting a much larger number of entities have access to medications for patients with substance use disorders. This has a lot to do with disclosing information for information exchanges, central registries, research institutions, and governmental organizations. And again, I want to just state, this is all in an attempt to improve treatment by the ability to share information. This final rule also says that methadone programs, which have never given information to prescription drug monitoring programs, now can, again, subject to patient consent and subject to the clinic wanting to do it, can provide information to CASPR that a patient is enrolled in a program and receiving methadone. And this is some of the things in terms of different organizations who will now be privy to information. 42 CFR Part 2 final rule will also address communications using personal devices within clinic settings, as cameras and videos and taping all become an issue of confidentiality recording. But the emphasis, consent must be obtained prior to disclosure and must be in writing. And this is just a short summary on some of the things that I have discussed. Let me talk to you about what the Kentucky Board of Medical Licensure is saying to you during these times. They understand that the standards of acceptable and prevailing medical practices that apply under normal circumstances may not apply in a state of emergency. They definitely emphasize, when possible, use telehealth technologies. Please consider that. It needs to be considered on a case-by-case, patient-by-patient basis, but we need to limit patient and staff exposure. They recognize that whereas you would prefer to refill prescriptions, particularly for controlled substances, with a face-to-face office visit, this may not be in order, and considering refilling prescriptions, perhaps even without a visit, but perhaps by telehealth rather than an in-person visit. They recognize that patients in treatment for opioid use disorder and an OBOT program require regular appointments, particularly to initiate treatment, both in OTPs and in OBOT. Maybe it's better to gather information via telehealth, via telephone, before bringing them to the office. And it is recognized that for OBOT treatment, a face-to-face will not be necessary during this period of time. This has not been changed for OTPs, which still will require a face-to-face visit before initiation of treatment. The board recognizes that this state of emergency is a fluid environment. The board understands the fine line of balancing treatment of individual patients with the protection of others. Circumstances change. KBML is asking that you use good judgment, good sense, good documentation, explain and justify what you're doing, and they've got your back. Lastly, let me talk about the AMA, and the AMA has come out with some guidances during these times, both to address just treatment of opioid use disorder in general, treatment of substance use disorders in general, but as well some of the flexibility necessary during coronavirus pandemic. Flexibility is a priority. This includes authorizing prescriptions for buprenorphine for treatment to new and existing patients based on an evaluation via telephone, just as the KBML has supported. That medications for treatment of opioid use disorder and for overdose prevention need to be considered essential services. The AMA wants to support increasing research into treatment for substance use disorders, wants to expand the cost sharing and the ability for patients to manage treatment without cost being a barrier. Definitely support that blanket exception for opioid treatment programs in which patients get extended take-homes. More and more programming needs to occur to maintain offer treatment in criminal justice settings, bringing methadone and buprenorphine, and this is something that is being worked on locally, to the criminal justice system is crucial. Greater flexibility in prescribing without a face-to-face, prescribing over state boundaries, refills, waiving limits in prescriptions for controlled substances. All of this needs to occur in general, of course, with caution, but especially during these pandemic times. And you can see here in these slides, these are for reference. You can see that there are some links here to more information that you can get on your own. Harm reduction, crucial. Naloxone, syringe services programs, which not only offer syringe exchange, but also offer a variety of other services for patients who have need. And this is more speaking to needle exchange programs. And that is my last slide. Again, I appreciate speaking to you. There may be some nuances in interpreting some of these rules and regulations. I do refer you to the KBML and KMA if you do have more specific questions. But I am open to anyone communicating with me. My email address is mjorri8481@yahoo.com. Feel free, and I'll be happy to answer any questions that way. Thank you.
Thank you so much, and we appreciate you being with us again today, and look forward to hearing questions from our audience remotely, and we will send those to you. The KMA staff will be happy to send those your way and to hear back from you on the answers to those questions, which we can possibly then provide on our website. So thank you so much for being with us today, and we appreciate your time immensely.
You're very welcome. You have a good rest of the day.
You as well.
All righty. Bye-bye.